The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hello, everybody, and welcome back to the FlightBridgeED MDCAST and our obstetric critical care series. My name is Mike Lauria. I'm an EMS physician, ER physician, and critical care physician here at the University of New Mexico. And we are here and back with our special series on OB critical care transport. Now, remember, going back a little ways, we started this because we do have a little bit of a problem in our country. Unfortunately, the mortality rates for obstetric patients have been on the rise. In fact, over the past 10 or 20 years, we've kind of slid to about 65th in the world in terms of OB mortality, which is really not good. And unfortunately, it's gone from about 17 or so to around 32 or so deaths per 100,000 pregnant women, which is really not great. And of course, we play a role in that as critical care transport specialists. And it's important because actually a large number of these births and a lot of the peripartum care takes place at small facilities that really don't take care of a lot of babies or pregnant patients, less than 1,000 deliveries per year. So roughly a third, about 37%, are probably going to have to come to places with OB critical care services. And that, of course, is where we come in. So that's what this series is about. And back to join us and my helpful sidekick on this whole series, Dr. Elizabeth Garchar, one of our flight physicians and one of the only obstetric flight physicians that I've ever met, is here helping me with the podcast. Of course, Elizabeth and I have no conflicts of interest, no financial conflicts anyway. We're very conflicted in the sense that we love OB critical care. But just remember, to everybody who's out there, that we are discussing some of the evidence, some of the science and best practice as we see it, and some of what our organizations and institutions will do. However, please remember that's not a substitute for your local protocols, guidelines, regulations, or laws. Always stick to them. Now, today is a particularly special podcast in our series. We are joined by a very special guest, Alixandria Pfeiffer. Am I saying that correctly, Alex?
Pfeiffer, yes.
Pfeiffer, I'm sorry. Alixandria Pfeiffer, who is a maternal-fetal medicine specialist and also an OBGYN at the University of Texas Health in San Antonio. So we'd like to offer her a warm welcome. Welcome to the podcast, Alex.
Thank you. Thank you so much. I'm super honored to be here. Yeah. Like you said, my name's Alex Pfeiffer. I'm a first-year maternal-fetal medicine fellow actually at the University of Texas Health San Antonio. I completed my OB-GYN residency there and just got sucked into all things South Texas. But yeah, I had the opportunity to meet Dr. Liz Garchar through the SMFM meeting. That's kind of the big annual meeting where all of the MFMs throughout the country and related personnel come and you know, we talk about all things high risk pregnancy. So Liz and I are both on the Health Policy and Advocacy Committee, and so that's where we initially met, and we realized that our interests were pretty much one and the same with regards to all things OB transport, especially. And so we connected, and here we are. But, you know, for me, my interest in OB transport started over about 5 years ago at this point. My research interests were spurred after several conversations with specifically my OB transport nurses at my institutions. They would discuss events that happened, you know, intra-transport and come back to OB triage. And it just sparked a lot of questions for me, even as an intern. And one question led to another, which led to another and to another. And so here we are today. But I'm so excited to have the opportunity to speak with you guys today and hopefully join you all in this journey of furthering OB transport education and hopefully potentially protocolizing some of what we talk about and what we see.
That's absolutely.
Super. Thanks for coming today.
Yeah, great to have you on. And I think that the other really interesting thing that really grabbed my attention was when Liz was like, she did this research on like flight physiology and monitoring and transport, which I think is a question that we that seems to come up over and over again. Like, how does actually flying a pregnant patient affect them? What should we be monitoring? How we should do things? So why don't we start out with a little bit like specifically with regard to this question of monitoring and flight physiology for mom. How did that come up? How did you get interested in that piece of things?
Yeah. So, as I mentioned, my question was initially spurred from our obstetric transport team, and I would be the physician that would, accept these patients on, after they've been transported. And so discussing their intra-transport events with our OB nursing staff really started to spark those questions, like I mentioned previously, where they would say, oh, it was a little difficult to monitor this patient because of, X, Y, and Z, or because of what was going on, or because of her pain and contractions, and, or the rotary interference from the helicopter really made it difficult for me to monitor this kiddo, or, the mom was very hypotensive, and so I didn't have the opportunity to monitor as correctly as I could. And so again, those questions and those anecdotes that my nursing staff would come to us with after transport really sparked a question. And when I tried to dive deep into any sort of literature review, I saw there was absolutely zero contemporary research on anything with regards to how to do OB transport, when to do it, why are we doing it, all those things, and what does OB transport look like from a physiologic standpoint for both mom and for baby. As we know, these patients are already at a high risk for morbidity. And so again, that furthered my interest for really trying to dive deep and establish a good sort of research database that we can use for hopefully the rest of time.
Nice. That's awesome. I think it's really cool actually that it came from the transport teams. Like some of the nurses were like, well, how, why would you do this? Or we run into trouble sometimes, and is it worthwhile? Does it help? And what are we really doing? Because I feel like that's a question that comes up regularly, which I'll say, well, just taking a step back as it comes to monitoring. One of the things that crews have come forward with and questions that I've gotten is, well, what's the utility of continuous fetal monitoring and tocometry, especially in transport? Because one of the things I usually hear is, hey, I've been told that, it really doesn't affect outcomes. And, why can't we just, get a Doppler before we leave and then, like right before we land or something like that. So I'm interested to hear both your opinions on why should we be doing this in the first place?
So I think that when, essentially fetal monitoring continuously was first introduced, that it was thought that if you're watching constantly, you're going to catch things and prevent things such as hypoxic events or other injuries to the fetus. And also, of course, mortality in the fetus as well. So delivering before that or during that terminal bradycardia prior to death. But what it's really demonstrated is that it doesn't predict those things, that it really ultimately predicts not a whole lot. It mostly increases cesarean section rates because we see these moments when babies are having maybe a mild time of bradycardia that would resolve on its own without monitoring, but we don't know, and it would make us too nervous to wait, 6-7 minutes and just wait and see what happens, essentially. So although it's used widely and it's really something that is standard of care, because now if you don't watch and something happens, of course, that would be a terrible event that could have, in theory, at least been prevented with monitoring. So unfortunately, it hasn't played out that it's super helpful, but I think in a lot of ways we can't not use it at the same time, right? Because we have this at our disposal. And if we're seeing something like this baby has recurrent decelerations throughout transport, then we're going to comment on that to the team, and maybe they would move back for cesarean right away, even if the evidence hasn't demonstrated that that's going to help baby outcomes.
Yeah.
Gotcha.
Yeah. I love that, Liz. I totally agree. I think for us at our institution, we have the technology, and so we got to use it. We ethically can't do any sort of RCTs or anything like that we're looking at monitoring versus not, just for some of the reasons that you had said, Liz, where, if we do miss terminal bradycardia and we do have that technology on hand, how do we explain that? So for us, we use CFM, or continuous fetal monitoring, as a form of a fifth vital sign, just like you kind of alluded to, Liz, where maybe if there are events happening intra-transport, we can relay those events to the accepting teams and maybe mobilize for whatever we need, really mobilizing for delivery if we need to sooner rather than later.
Gotcha. I think that's a really good way to frame it as well, is that, because one of the other comments that we've gotten as well, what am I going to do if I do see something, I can't deliver a baby? Well, I think you brought up a really good point, Alex, that mobilizing resources, and preparing resources on the receiving end, whether, it's, CFM that's showing, issues, or whether it's mom's deterioration in flight, or whether it's a clinical issue with a non-obstetric patient, getting that information early and mobilizing the hospital resources quickly, I think is really important. So on that note, sometimes, I'll be honest, like I don't work in OB. I struggle with this on transports too, keeping the monitoring set up so that we get everything in a good axis where we can get an interpretable tracing seems pretty challenging sometimes. So for all of us in the critical care transport world, with both your experience, can you guys give us some tips on how best to get good tracings and maintain those tracings in flight?
So the first thing that I would say about that is definitely like when you're at the hospital, establishing like your fetal monitoring before you leave bedside, of course, that like is a quick way to have had your OB nurses give you a huge hand as to where the spot is. Because sometimes it can be really tricky and you need like a little washcloth in there to tilt it correctly or something like that. So making sure that you have that. The other thing I do is ask mom, like, where do you usually feel kicks? Because especially depending on gestational age, once you get over, especially 32-ish weeks, babies aren't turning a whole lot. They can, but it's unusual. And definitely by 36, they're often in their kind of final resting position. And so she says, I always feel kicks at the top of my belly on the right side. Then you can think that that's often where the feet are going to be. And so you're going to want to put your monitoring below that. Or if she says like, oh, my baby's been breech and I feel them in my cervical area, then you're going to want to put it a little bit higher. And I would always start kind of somewhere around like the middle of their protuberant sort of abdomen and go from there, kind of tilting side to side. And then the other thing I do, because I love it and I'm an ultrasound oriented MFM like that, is that I just keep my butterfly or my transportable ultrasound on hand so I can always find the heart and move it to that spot.
Alex, what about you? Pro tips for people?
I think basically they're all along the same lines as Liz had mentioned. I think establishing that pre-transport spot, like Liz had mentioned, that hot spot that that baby's likely going to lie in, is probably the most important for intra-transport monitoring.
That makes sense. I'm going to work on that. We'll practice it. The towel tilt, that's something I haven't tried. I'll have to give that one a shot. All right. Okay. Getting back to Alex, what you had talked about and the poster presentation that you had done, let's dive a little bit more into. I know you had mentioned that some of your nurses had come to you and expressed some of the challenges, and you had already kind of started talking about this. But what were some of the specific things you were interested in looking at, and why? I mean, there's got to be national standardized protocols on this or something, right?
Well, no. Unfortunately, there aren't, but yeah, no. I mean, given the anecdotes that my Stork 1 nursing staff had with regards to continuous fetal monitoring and rotary interference and changes in contraction pattern and things of that nature, we sought to describe feasibility, right? And so we've already kind of alluded to that just in this conversation. Is this feasible? Is this something that we can do? And we really wanted to understand the fetal and maternal changes that happen during transport, specifically from a physiologic standpoint. And so we not only wanted to look at that, but we also wanted to detect differences, if any, by transport type. And so, yes, unfortunately, there aren't any standardized protocols. There aren't any current consensus with regards to the effectiveness of CFM during transport from tertiary centers to for emergency care, and there aren't any research documenting possible effects of atmospheric and rotary influences on fetal tocodynamics as well. And so it's a gold mine.
Awesome. So what did you guys think you were going to find as far as looking into those things?
Yeah, so, our hypothesis was pretty simple because this is no man's land, we kept things quite simple. So we hypothesized that CTG or cardiotocography monitoring is feasible in depicting fetal status and well-being during maternal transport. And secondarily, it's expected that there may be physiologic changes that occur during flight. During flight transport, such as a potential decrease in maternal oxygen saturation and even an increase in pulse.
Oh, what kind of study did you design for that?
So really, we just looked at we created a retrospective cohort study where we evaluated CTG in all maternal transports for about 2 years at our institution, which is a level 4 maternal care facility. We looked specifically at patients with singleton, non-anomalous, viable fetuses. For us, we define that as greater than 24 weeks. And those patients were our candidates. Each patient served as their own control. So again, we kind of already alluded to this, but each patient would have a pre-transport assessment. So we would look at maternal vital signs before transport and what we call a 20-minute MST was, or what it looked like before transport. And so we would do a 20-minute monitoring session on those babies before transport. And then we would do that again, obviously, intra-transport. All transports involving CTG monitoring included nurses that were trained in high-risk obstetric transport. All patients had a pre-transport and intra-transport assessment, like I mentioned, and we analyzed this further by type of transport. So, was it a flight transport, and specifically, was it a rotor or a helicopter transport or a fixed-wing transport, or as we know, as an airplane? And then we also looked at ground transports. We assessed physiologic changes through the analysis of vital signs, which were further analyzed retrospectively a little bit later on in 2021, specifically by transport type.
That's awesome. I think that's a great design, but I always think that it's really important to look at those primary outcomes, or like, what are you looking at with this? So what did you look at with that?
Yeah, so we essentially broke this out into kind of two studies. So again, trying to keep it simple, again, because there isn't really any research on this at all. So first, we wanted to look at, from a feasibility standpoint, we want to look at the proportion of transports where monitoring was feasible by transport type. And then secondarily, within that kind of category, we wanted to look at the proportion of transports with where we saw a change in fetal heart rate baseline, a change in fetal heart rate variability, and those who develop a composite of abnormal fetal heart rate changes, like bradycardia or tachycardia or recurrent decelerations in the heart rate, things like that. From a physiologic standpoint, kind of under that umbrella, we primarily wanted to look at the degree to which maternal physiologic parameters are influenced by during transport. And then secondarily, we wanted to look at the degree to which those parameters and fetal CTG are influenced by altitude during flight transport as well.
And then what did you come up with?
We actually surprisingly had a really, really high feasibility rate. Again, all of these questions that our team had were sparked by anecdotes by our nursing staff. But, what we found was that we achieved a 92% CTG or cardiotocography feasibility rate, which was awesome. A majority of our transports were either flight or were by ground. And from a flight standpoint, majority of our transports were by rotor or helicopter, with only a small subset, only 3 of the cohort that we looked at least were fixed wing. And in our fixed wing population specifically, none of the transports had difficulty with achieving continuous fetal monitoring, which I thought was interesting. I think running through the results, that was probably due to the fact that, fixed wing transports are closed pressurized cabins, right? You're not dealing with those atmospheric or rotary interferences that you would with a helicopter transport. So we thought that was interesting. And again, an ode to doing CFM in transport.
Can I ask one question? Alex, What do you think were some of the things that led to the CTG not being feasible?
That's a great question. When we looked at specifically the BMI of our patients, the BMI on average for our patients ranged between about 27 to about 32. When I looked specifically at the instances where monitoring was not feasible, it was either for twin gestations or for, unfortunately, our larger BMI patients. And so it was just a little bit more difficult to assess. And then thirdly, it was our patients who were in a smaller gestational age, so 24 to 26 weeks of gestation were a little bit harder to assess.
Gotcha. So smaller, perhaps harder to monitor babies, and some of our patients that have a slightly higher BMI. I feel like that also makes sense. Would you agree, Liz? Especially sometimes getting our patients onto the helicot or the air cot system can be challenging in and of itself. It's not exactly designed as nicely as some of the ward beds in the hospital. And so that kind of makes sense.
Yeah, certainly. Especially it being sort of an OR sized bed, very small, lots of confined space. So it can be difficult to get everything in there. Super interesting stuff for sure. And how about the physiologic changes as far as the fetus and mom?
So from a physiologic standpoint, we interestingly found that in flight, particularly, maternal oxygen saturations were noted to decrease by approximately 1.5 percentage points as compared to ground transport. When we further stratified this by altitude, we looked at the flights that occurred at heights less than 3,000 feet and at greater than 3,000 feet. Why we chose 3,000 feet was just literally the middle. It was the median altitude achieved during our flights, and so we decided to separate it out just based off of that. And so at heights greater than 3,000 feet or equal to 3,000 feet, we saw that oxygen saturations decreased even further by 2.5 percentage points. This wasn't statistically significant, but there was a statistical trend towards that. And from an outlier perspective, one of our transports got as low as 4 percentage points lower from their baseline in that pre-transport assessment. But yeah, so I think in general, our trend was for a decrease by 1.5 to 2 in oxygen saturation. Furthermore, what I thought was interesting, and Liz, I don't know if you've seen this specifically on your personal transports, but we saw quite large decreases in systolic blood pressure. This unfortunately wasn't statistically significant, but we did see a statistical trend. So in our flight transports, we saw systolic blood pressures on average going down by about 5 millimeters of mercury, whereas, and then again, further stratifying that out by altitude in the transports or in the group that flew at heights greater than 3,000 feet, we saw on average almost a 10-point decrease in systolic blood pressure, which I thought was quite interesting. And if you look at our outliers, for one of our transports, it was a negative 34 point decrease. And so, I thought that was very, very interesting. And currently we're doing more studies on a larger cohort, or we're looking at a longer time period to assess that. And I'm fairly positive we'll probably achieve statistical significance just preliminarily looking at our data.
Yeah, that's super interesting. I would say that I've noticed that we definitely have to rescue a lot less in transport as far as a severe range blood pressures for preeclampsia. So it's really interesting because I can see how that would be exactly.
Yeah. And I think, as you have already said, for our patients that are being transported for PIH or pregnancy-induced hypertension, or even those that have an exacerbation of their chronic hypertensive disorders, this has implications to baby, right? And, if the baby is used to a certain environment where it's seeing very large increases in blood pressure, and all of a sudden in transport for this moment of time, we see these transient decreases that could be significant to the fetus. What does that look like? And what is that? How does that impact the baby? And so these are all things that we're hoping to look at, and what we are looking at going forward. And we're hoping to, create some sort of sensitivity analysis to maybe predict some of potential morbidity with regards to that. But yeah, very, very interesting regardless.
Yeah, I thought that was particularly fascinating and hypothesis generating, even if not statistically significant. And I think one of the other things is that I think most of us who work in like an adult ICU or the ED and fly not pregnant patients, non-obstetric patients regularly, we'd be like, like a decrease in a couple percentage points on their O2 sat, whatever. And a lot of the time we have patients that have COPD and other underlying pathologies where we're pretty liberal with, their oxygen saturations. This population, however, is not a population that I think any of the guidelines suggest we can be that loose and liberal with as far as letting their oxygenation saturations drop. So I would say that although it's a small difference that is statistically significant, it may in fact be pretty important. So I thought that was pretty fascinating.
Right. Yeah. As you all know, but for our audience here, from a maternal physiologic standpoint, your oxygen saturation needs to be above 95%. And so if just based off of these studies that we've done thus far and some of the data that we're already starting to pull in, if moms are found to be decreasing their oxygen saturation by 2.5 percentage points, is this something that we need to remark on? And is this something that we need to protocolize in terms of oxygen therapy and transport? Should we be applying 2 liters nasal cannula in transport across the board because of these fluctuations that we're seeing in oxygen transport? And it's something that, I think we'll definitely need to really ask and look at critically. Yeah,
and it is something that even here, even at, we have, our altitude is 5,000 in Albuquerque and, 7 in Santa Fe, and we still say 95% for pregnant women. So we still have really high standards. I agree, Mike, that there's not a whole lot of wiggle room. Well, overall, I would say you have really great, awesome, novel study here with lots of really good information. And what would you say were the limitations, though, of this study?
Right. Yeah. So overall, we do think that CFM, or continuous fetal monitoring, CTG, whatever you want to call it, is definitely feasible during maternal transport, without any notable changes noted, at least by transport type, based off of our study. There is an apparent change that happens from the maternal standpoint with regards to oxygen saturation, and in those especially transported by air. And, we definitely should begin to consider updating current physiologic thresholds, as we had previously discussed, when undergoing maternal transport with regards to maternal physiology. We hope to eventually develop some sort of protocol that we can standardize with the help of y'all and other institutions across the country who are also doing maternal transport.
That's awesome. I think this is a really, really cool, very well put together feasibility study that at least begins to open the door and look at some of these issues, which has just not been studied. And that's one of the interesting things I feel like with our critical care transport world overall, and definitely in the obstetric setting. A lot of these questions, the question is not what to do. It's like where to start. And this, I think, was a excellent starting point. So thank you so much, Alex and Liz. As always, we look forward to having Alex on the podcast some more as we explore some really, really cool topics in OB critical care transport. So thank you, everybody, very much. Take care, fly safe, and we'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.